Good afternoon, everyone. My name is Rebecca Malillo, and I'm a project manager with the Community Outreach and Engagement team. It is my distinct honor to welcome you to the Sidney Kimmel Cancer Center's first Conversations About Cancer, Recovery, Research, and Reducing Your Risk. Our topic today will be colorectal cancer as we close out the last day of Colorectal Cancer Awareness Month. And we are joined by Sidney Kimmel Cancer Center's experts, as well as advocates from the Colorectal Cancer Alliance and the Camden Coalition. Each panelist will have time for Q&As, so feel free to comment any questions on Facebook as they're sharing their stories and information. The Colorectal Cancer Alliance, or formerly the Colon Cancer Alliance, believes colorectal cancer is a senseless killer that must be stopped. Founded in 1999 by survivors, caregivers, and friends, the Alliance is the nation's leading nonprofit dedicated to colorectal cancer. They empower a nation of allies made up of patients, family members, caregivers, survivors, researchers, and clinical professionals, working with us to provide genuine support for all who need it, to raise awareness of preventive measures, and to inspire efforts to fund critical research. United in our fierce determination to dramatically impact the way society sees this devastating disease, they exist to end colorectal cancer in our lifetime. The Alliance has and supports resources for the entire nation of allies. Visit their website to find news, information, and the answers needed to keep advancing research, treatments, and prevention, and we'll share those links at the end. We are also joined today by our local partners at the Camden Coalition. The Camden Coalition is a multidisciplinary nonprofit working to improve care for people with complex health and social needs. Their work to advance the field of complex care is through implementing person-centered programs and piloting new models that address chronic illness and social barriers to health and well-being. Supported by a robust data infrastructure, cross-sector convening, and shared learning, their community-based programs deliver better care to the most vulnerable individuals in Camden and across our region. Specifically relating to our topic today, their pilot program helps residents in Camden County who are due for colonoscopies but are facing barriers that prevent them from being able to get to the procedure. This pilot uses a nursing and community health workforce to help navigate patients through to the procedure. Their hope is to bring to light barriers associated with colonoscopies, as well as to bring awareness to the community that screening can and does prevent cancer, and that help with getting screening is available to you. Thank you to both the Colorectal Cancer Alliance and the Kimmel Coalition for joining us today. And with that, I will welcome our first panelist speaker for the day, Dr. Ana Maria Lopez, to share the basics of colorectal cancer screening and prevention. Dr. Lopez.
Thank you.
Dr. Lopez is professor and vice chair of medical oncology at Sidney Kimmel Medical College and chief of cancer services at the SKCC in New Jersey. Dr. Lopez also serves as director of integrative oncology at the Sidney Kimmel Cancer Center. Dr. Lopez graduated from Jefferson Medical College at TJU and completed her internal medicine residency, chief residency, general medicine fellowship, hematology and oncology fellowship, cancer prevention and etiology fellowship, and MPH at the University of Arizona. She subsequently joined the faculty at Arizona Cancer Center, where she served as the founding medical director of the Arizona Telemedicine Program, professor of medicine and pathology, and associate dean for outreach and multicultural affairs. She was the site medical director of the Women's Health Initiative, the largest NIH-funded clinical trial focused on women's health outcomes. Dr. Lopez has served as the principal investigator and co-investigator for multiple cancer prevention and therapeutic trials. Dr. Lopez is board certified in medical oncology and integrative medicine. Her clinical expertise is in women's malignancies, integrative oncology, and innovations in healthcare, including telehealth. Dr. Lopez is president emeritus of the American College of Physicians, the largest medical specialty organization in the United States. She has dedicated her career to nurturing health equity, increasing wellness and well-being in patients, clinicians, and communities. So good afternoon to Dr. Lopez, and thank you so much for joining us today.
Thank you. It's such a pleasure to be here. And thank you to everybody who's watching in Facebook land.
Can you start by telling us a little bit about what colorectal cancer is?
Sure. So, cancer is not one disease. It's really, really multiple. And colorectal cancer, similarly, is likely multiple factors. And we're learning so much about the molecular aspects and what happens. So we believe that colorectal cancer begins with these polyps. And those are just growths that are happening inside the colon, and that they can happen for multiple reasons, some of which are completely benign, meaning that they don't have a risk for cancer, and some which may lead to cancer. And because of that, because there's time between that first polyp and the cancer, there's opportunity for actually preventing the cancer from developing. So colorectal cancer, a process that takes time. We could talk about maybe different things people can do to try to decrease their risk, but really can in many cases be detected early.
Absolutely. So that was actually my next question, if there's anything that we could do to help prevent this type of cancer.
Sure. So I really want to stress this, that for screening, so screening are studies that can be done in order to detect cancer early when it's most likely to be curable. For colorectal cancer, because there's the opportunity to do a colonoscopy and perhaps identify pre-malignant lesions, the screening test itself is a way to decrease risk, because by removing that polyp, that whole process that is leading to the cancer can be stopped. So that's very, very unique for colorectal cancer. And then, I'm so impressed that what we have learned over the past 20 years is a lot of molecular changes, which are tremendously important. But we've also learned a lot about the impact of wellness. We've learned that nutrition, which makes so much sense, right, for colorectal cancer, since what we eat goes through that digestive system, it makes a difference. That exposing our bodies to toxins and chemicals, which again makes sense, can be harmful to us. So trying to eat healthy, primarily a plant-based diet, increasing our fiber so that things move along. And we can also help things move along by ourselves staying mobile, by ourselves keeping our bodies strong and active, that's also helpful. And we know that so much health and healing actually happens when we sleep. And there's an amazing diagram which really shows the progression of colorectal cancer from polyp to a frank cancer, and how that's accompanied by different molecular changes. The healing that could prevent those changes can happen while we sleep, part of that healing process. So sleeping, so I feel like it's all the things our mothers told us: eat well, sleep well, move our bodies, and really find joy.
Can you tell us a little bit more about the screening? So what are the screening guidelines, and what does the screening for colorectal cancer look like?
Sure. And what's part of the message that we're trying to get out is 45 is the new 50. It used to be that the guidelines were to get screening at the age of 50, but we're seeing that younger and younger people are being diagnosed. So 45 is the new 50. We are everybody average risk. Now, this is for average risk people. If you have a family history, that might even be younger. But for average risk people, the recommendation is 45 and up to get screened. And there are multiple approaches, which again is the beauty of colorectal cancer screening, that it doesn't have to be just one option. But I'll only talk about two, because I think these are the ones that probably have the most success. One is a stool-based option, and we actually have a study that we're trying to that we're doing to help people get screened. But one is a stool-based test, and it detects blood in the stool, and blood in the stool can be an early sign of colorectal cancer. An annual test called the FIT, so FIT, and very simple. You can talk with your doctor. Many areas, are using this as a test, and you pick up the kit, you go home, and when you're ready to have a bowel movement, just do the preparation to be able to collect a piece of the stool sample, and then you send it back where it's processed in the lab. So it's done at the person's convenience. The other is a visual test, so that the physician can actually take a look through the entire colon and see, are there any of these pre-malignant changes, or is there a lesion that may be malignant? And that study, the colonoscopy looks at the whole colon. The flexible sigmoidoscopy does not. So if you want to get the full screening, it's the colonoscopy. Now, the colonoscopy does require a prep, and that's something that people sometimes are hesitant about, because the day before, the person would drink a specific prep and would really need to stay near the toilet so that as much as possible of the stool can be evacuated. And most people are surprised that there's that much stool in there. But very, very important to have as best of a prep as possible, so that when the physician looks in, the person can see well. So those are the two: a stool-based test and a visual test that can be done.
Thank you. So we have our first questions from the audience. How can you find cancer early? My in-law had colon cancer, but when she was diagnosed, it was already stage 4.
Yeah, so again, not 100%, but the goal is that by starting screening at the age of 45, being able to find, through these screening tests, being able to find disease early when it can be potentially cured, it's more likely to be cured, and also to be able to find, so let's say a person does the FIT and it's found to be positive, then a colonoscopy is recommended. Then we need to go in and look. And again, hopefully at that point, by starting the screening early, if there is a change, maybe it's a polyp, and then it might be a pre-malignant polyp, and the person just needs a follow-up in 3 years. So it is through screening that we hope to find disease early.
Are there any other signs and symptoms that people should be aware of?
Sure.
And mention to their doctors?
Sure. So again, really important to have a primary care physician. I really feel like people that do primary care are saints, because there's so much that they need to cover. But if you have a question or concern, always talk to your clinical team. But some changes could be changes in bowel habits. So if you normally have stools after breakfast every morning, whatever your usual pattern is, if there's a change in your usual pattern, talk with your doctor. If you notice blood in your stool and you're convinced, oh, that's just the hemorrhoids acting up, talk with your doctor. Better to be sure than to be wondering. Abdominal discomfort can be a vague symptom, but could be a symptom. So if you have, again, any concerns, any changes, it's really the concept if there's a change from your usual. And then we know with disease, as it advances, there can be things like loss of weight that's unintentional. Unintentional loss of weight is always a clinical concern.
Great. So we have time for one more question. Can you tell us a little bit about the treatment options that are available for colorectal cancer?
Sure. As far as treatment options, the goal, if it's if it's caught early, it might even be that colonoscopy takes it all away. Like, that would be the most amazing, right? If the next step is surgical excision, so that area of the colon that's impacted can be removed. Lymph nodes can be checked, which our entire body has lymph nodes, and our lymph system is so amazing because it helps clean the body of waste. So the lymph nodes would be examined. But again, if it's early, that might be it. If it's a little bit more advanced, there might be the addition of radiation. And if it's a little bit more advanced, and it also depends on the location, and if it's a little bit more advanced, it might include chemotherapy, which, chemotherapy is just a very broad term about using chemicals for the treatment of cancer. But now we have, in addition to this concept of chemotherapy going in and killing cancer cells, there's the concept of targeting, because we know so much more about the molecular changes, and the concept of immunotherapies as well.
Well, thank you so much, Dr. Lopez, for your clinical expertise. It certainly sounds like there's a lot we can do to work to prevent and identify early. If you had one key message for participants or anyone on the video today to take home, what would that be?
Screening saves lives. So you can save your life, and you can save your loved ones' lives. I used to do this campaign for Valentine's Day, and it was like, take your loved one to the colonoscopy and take yourself. But really, screening saves lives. And when people have advanced diagnosis, it's not 100%, but we want to prevent advanced diagnosis.
Thank you so much for all of your information and for joining us today. So next, we are joined by a patient advocate with the Colorectal Cancer Alliance, Ms. Verna Cox. Verna Cox is a retired Avon District Sales Manager, a wife and mother of 2 grown children and 3 grandchildren. During her 30-year career, she survived not 1, but 2 bouts of stage 3 colon cancer. Her decision to fight back and understand the nature of her ailment presented research that African Americans had a greater incidence of colon cancer that stems largely from lack of access to early diagnosis and treatment. After recovering from the disease, she became an advocate for awareness, making it her mission to educate and empower others about this disease. She volunteers with the Colon Cancer Alliance, doing community outreach, addressing fears, misperceptions, and lack of awareness that can keep African Americans from getting screening colonoscopies. She has lobbied on Capitol Hill for improved legislation and continues to be an advocate to fight colorectal cancer. Verna, thank you so much for the advocacy work that you do every day and for joining us today to share your story.
Thank you for having me. I'm excited and grateful to be here. And with yesterday being National Doctors Day, I do want to recognize both of my wonderful Jefferson Health physicians, my surgeon, Dr. Joe Eisenberg, and my oncologist, Dr. Edith Mitchell. I was diagnosed with colon cancer when I was 48 in 1998. I did not have regular symptoms. I didn't lose weight. I didn't experience any rectal bleeding, and I didn't have any change in my bowel movements. Mine was strictly a cramping in my abdomen. And for 6 months, I constantly went out to my primary care physician. And every test that my doctor sent me out to said that I was fine. So colon cancer can be a very silent disease, and that is why screening is so important. Finally, at my 6-month time, I told the doctor that I knew that something was wrong, that these pains were getting more and more constant and sharper. And that is when he scheduled me for a colonoscopy. And the results came back that I had colon cancer. When I called my aunt to let her know that I was going into the hospital to have surgery, she then told me, oh, don't worry about it, because I had it 3 years ago. So mine was a family that did not talk about cancer. What if I would have known early on that colon cancer ran in my family? So I had my colon resected. The surgery was performed successfully. And then I went through 6 months of chemotherapy. And I was very fortunate that I was asked to participate in a clinical trial. Clinical trials are so important. I just felt that that would be a way that I could give back and help someone else. 5 years I was followed, and I had no reoccurrences, and I thought that everything was hunky-dory. And then on my 7th year, I thought I had food poisoning. I was in Miami vacationing, and it turned out that I had developed gallbladder. And when I came back to Philadelphia, my doctor suggested that I have a colonoscopy, and lo and behold, my cancer had returned. And this time, instead of having infused chemotherapy, I went with an oral pill, which was so much easier. When I was recovering, Dr. Mitchell spoke to me about becoming an advocate, and I did. And I'm so glad, because I wanted to see what I could do to help others. And I was amazed in going out in the community how many people are unaware of even having a colon. I think if we might have said your behind or your rear, it could be something that they could visualize. Many people did not know that both men and women have colons. I've actually had people tell me that they were concerned that it could affect their sex life. I mean, you would be amazed at the misconceptions, how people fear having a colonoscopy because they think it would be painful. You know, explaining to them that, pardon me, that they would be sound asleep. Again, colon cancer can be a very silent disease, but what I've learned is that you have to listen to your body. And it is important. And with African Americans, we recommend that they don't wait till 45, that they consider having a colonoscopy at the age of 40. My daughter was able to have her first colonoscopy at 34, and she had polyps. So again, a polyp undetected could lead to colon cancer. So thank you for letting me share my story.
Thank you so much for sharing that with us. We do have a few questions for you. Can you touch on, you mentioned that, once you had been diagnosed, you found out that your aunt also had cancer. And this is something that we see pretty commonly as people don't talk about cancer. So can you touch on any tips for people that might be asking for family history or sharing this kind of sensitive information, because now we know that family history does affect someone's risk so greatly?
Well, I think it's important that it be an open dialogue, that at this point, people, when they gather at family reunions, at funerals, whenever, that they often don't see distant relatives, that they talk about family history. Here my aunt apparently was very secretive, and it could have been something that could have helped me early on.
Mm-hmm. And what is the most important thing you've learned during your cancer journey?
That cancer is not a death sentence, that it can be preventable, treatable, and beatable, and that a positive attitude makes all the difference in the world, and that you need to ask for support. I had wonderful support from my family and friends, and everybody that knows me knows that I'm a colon cancer survivor because I constantly talk about it and share it and encourage others.
I think that's amazing. We need more people like you who are willing to share their story and share this empowering information. Can you share a little bit more about your experience with the clinical trial you participated in?
Well, it was a wonderful opportunity in that you get the gold standard of care. I met with my physician and their staff maybe twice a month. I was constantly tested and monitored, and I felt honored that and grateful that this type of care was accessible to me.
And you did this trial at Jefferson, correct?
At Jefferson, yes.
Excellent. We have to give a little shout out to our own physicians and our own research team.
Yes, under the care of Dr. Edith Mitchell.
Excellent. All right. And what has been the most helpful for you during your cancer treatment journey?
Knowing that there is hope, that a cure was coming my way, that all I had to do was do this 6 months worth of protocols, and then I could possibly be cured.
Excellent. And I will give you the same opportunity that I gave to Dr. Lopez. If there's one key take-home message or call for action that you'd like to share with everyone watching today, what would that be?
Listen to your body. Don't ignore any symptoms. It's God tapping you on the shoulder, letting you know something is amiss, and taking advantage of all the screenings that a person should have based on your age.
Excellent. Well, thank you so much for sharing with us today and for all of the advocacy work that you do. We very much appreciate you sharing your story. And with that, next we are joined by a cancer advocate with the Camden Coalition, Mr. Miguel Rodriguez.
Hello, good afternoon, everybody. My name is Miguel Rodriguez.
Hi, Miguel. Thank you so much for joining us. Mr. Rodriguez was born in Brooklyn, New York, to a large family. He received his education in Brooklyn, and from the time he was a youth, has felt a desire to help others. In 2013, Miguel developed some health issues. While in the hospital, he was visited by care team members from the Camden Coalition, who would go on to support him during his recovery journey. Since then, Miguel has volunteered with the Living Proof Recovery Center, worked with Donald Mays Community Wellness Self-Help Center, and worked with the Mental Health Association. Most recently, Miguel has been focusing on various advocacy efforts, including supporting people who are returning from incarceration. He is a 2019-2020 National Consumer Scholar, member of the Camden Coalition's Community Advisory Board, and sits on the advisory board committee of the Innocence Project. Miguel is also a member of the Coalition's Ambassador Program and is here today to share his experience with colorectal cancer screening. Thank you, Miguel, for all of the work that you do and for sharing your story today.
Thank you very much for having me. Hi, everybody. I'm going to my story. In 2019, I was experiencing some problem with my sex drive. And along with that, cramps in my private area. I was under the assumptions that it was coming from me being dehydrated or my lack of potassium intake. I kept asking myself what was the problem. I decided to do my own research on colon cancer. I discovered that the symptoms in which I was experiencing led me to believe that I may have colon cancer. My signs consist of the following: excessive gas, very skinny stool, feeling fatigue, loss of weight for no reason. I was in denial even after experiencing these symptoms. abnormal back pains. And on my next visit, I found myself explaining to myself as my healthcare provider and what my body was going through. She informed me if I had a colonoscopy screening done, at which point I informed her that I did not. She explained the procedures to me after my healthcare provider explained to me. I decided on getting my colonoscopy done. She scheduled me an appointment with the colonoscopy screening doctor. Upon my scheduled appointment, I explained to the doctor my symptoms in which I was experiencing. He further explained to me the procedures, the medicine that I had to take, and the 6 pills that would be added on to help me move my bowels, cleanse my bowels, cleanse my insides. To and from, and that if anything was found within my intestines, that the procedures would be scheduled, would be canceled and then rescheduled, because it had to be, but it tends to be real clean. Nothing could be in there. So again, I decided to get mine done, out of fear. I had a friend who had died from me. He never told anyone, and he never went and got it checked out. At the end, when he passed away, it was revealed that he had died from colon cancer. So, I got mine done, and it's important.
So thank you for sharing, and I'm sorry to hear that your friend had passed from colon cancer. So a few questions for you. Was there anything that was helpful in making you feel more comfortable about getting the colonoscopy or going through the prep? Anything that helped you feel more comfortable going through that process?
All the information that I was given, to make that decision, to know that, I was going to be okay. I was going to be harmed by, by what they was doing, no side effects and none of that, So it was pretty much their insurance, they ensured me everything would be okay,
And we are still in the middle of this COVID-19 pandemic time. So a lot of people are worried about, getting infected with COVID-19 and have delayed cancer screenings because of that. So there's definitely been a decrease in screening rates the past couple of years. Can you share, when your last screening was and why you decided to get screened during the pandemic?
My first screen was in 2018, and they found pilots. They found 4 of them, and then I was rescheduled to get it done in 2021.
Mm-hmm.
Had to go back every 3 years as opposed to every 5 or every 10 years, right? So I was scheduled to do it in 2021, which was a few months ago. I've gotten it done, and they found 5 more powers in me, and it wasn't during the pandemic. Like I said, I got it done in 2018.
Mm-hmm.
And then I had to get it done in 2021. By then it was slowing down, things was easing up some, when it first started, no one was allowed to get surgery or anything like that, because they didn't have this space in the room available, because everybody that was catching COVID-19 had to be quarantined. The hospitals was overcrowded, the people that was being quarantined. So I'm glad that it turned out that way. That was 2021, where it gave me the opportunity to get in there and get it done again.
And was there anything that either you personally or that your healthcare providers did that helped make you feel safer going into the clinic and having these appointments during the pandemic?
uh, well, my healthcare provider, if I never would have explained to her what I was physically going through, my body, you know, I never would have known. I never would have gotten the test done, the way she explained it to me. So for me, it was important that I share with my healthcare provider, what exactly I was going through. My body was one of the changes that I was experiencing. So she eased, she eased my mind. I was convinced now, on getting after doing my research, and I said, well, let me get this done. I heard of that on the self-help kits, right? You can purchase, but also I read that they're not really that effective. So I said, well, let me go personally and get this done. But I want to make sure, I want to make sure, that I'm okay.
Absolutely. And I think it's very important to advocate for yourself. Like you're saying, that's something a lot of people don't feel as comfortable with. So good for you for, taking, like Dr. Lopez mentioned, clinically, you want to notify your provider of any changes, right? So you did exactly what she suggested. And what do you think could have happened had you not gotten screened in 2018?
Well, because I'm stubborn, right? And I guess as I'm getting older, I'm starting to leave some of that stubbornness alone, and I'm trying to live a little bit longer. If it not, I would have wound up like my friend, because I was scared to get it done. Didn't want to talk to nobody about it, didn't feel the necessary to get it done. I'm like, well, I'm not gonna do that because they say that that they do it this way and do it that way, and for us, for like my peoples, and I know, for a lot of African American males, they don't want they don't want nothing going up, in their rectum. They know, to get a check, right? But that's a fear that listen, we have to get away from, and it's basically about our health, it's basically our life, right? And if you don't mind, let me impose this. There's one thing, right? I'm an ex-addict, right? So, I did heroin 39 years of my life. And if I was so willing, every time that I stuck a needle in my arm, playing Russian roulette with my life, killing myself, right? Why can't I go and get screened to save my life?
Absolutely. So we do have a question from the audience for you. Do you have any suggestions to talk to men about colon cancer screening? This individual said, we've had such a hard time convincing our uncle to get a colonoscopy.
Well, for me, it's to do your researching first, right? And like reassure him through the research, and that it's going to be okay. You're going to be okay. Nothing's going to happen. Have them talk with their healthcare provider once they do their research, and it's very important that you get it done. So I mean, like, people want to see proof, right? People want to see facts. Because I mean, there's a lot of stigma out there. When it comes to the Black and Latino people, there's a lot of stigma that they don't want to get it done. So I learned through my research and my advocacy is that people want to see proof. People want to see solid proof. So for me, like, and I'm glad he asked that question, because my boss's husband, he'd been talking to me about getting it done. Right. So it was just yesterday, I gave him information. I said, here, listen, what you're waiting for. This is what they do. This is how they go about it. I said, just call this number, right? And they'll set up a screening testing for you. So he said he was going to do it. But some people, they need facts. They want to see facts. So So I would strongly suggest that to convince someone to do something, please have facts, do your research, and let them see it for themselves, and then pretty much they'll decide then, like, yeah, okay, I need to get this done,
Absolutely. So if you had one take home for our viewers at home today, what would that be?
Go and get yourself checked. It's important for me. Every life matters, you know, you know, um, save yourself, don't kill yourself, you know.
Excellent. Well, thank you so much, Mr. Rodriguez, for sharing your story with us today.
You're welcome.
And that brings us to our final panelist today. We have SKCC's own Dr. Adam Snook here to share his knowledge and experience with colorectal cancer research.
Thanks, Rebecca.
Dr. Snook received a BS in pharmacology and toxicology from the University of the Sciences and a PhD in immunology and microbial pathogenesis from Thomas Jefferson University. He joined the faculty at TJU in 2013 in the Department of Pharmacology and Experimental Therapeutics, where he is still studying the mechanisms underlying colorectal cancer tumorigenesis and the interaction between cancer and the immune system to develop new options to prevent or treat gastrointestinal cancers. His work has led to 7 investigator-initiated clinical trials examining colorectal cancer chemo prevention, cancer vaccines, and CAR T-cell therapies. Dr. Snook has authored over 100 book chapters and papers in prestigious journals, including Cancer Research, Gastroenterology, Journal of Clinical Investigation, Journal for Immunotherapy of Cancer, Cancer Immunology Research, and Cancer Cell. He is currently an associate professor in the Department of Pharmacology and Experimental Therapeutics with a secondary appointment in the Department of Microbiology and Immunology. He is an assistant program leader of the Immune Cell Regulation and Targeting, or IRT, program here at the SKCC. He is also the director of the Clinical and Translational Research track of the Jeff MD Scholarly Inquiry Program of the Sidney Kimmel Medical College. So thank you, Dr. Snook, for joining us today, and welcome.
Thank you, Rebecca. We need to find a way to shorten some of the names of those departments, I think. So first, I want to thank Miguel and Verna for sharing their stories. They're really touching stories, and ones that I don't get to hear very often as a researcher. I'm typically, much more removed from the patient interactions in the work that I do, which is really about understanding colon cancer, how it forms, and ways we can prevent it, and ways where we can develop new therapies to try to either prevent it from coming back or to give new options to treat patients with more advanced disease. So we're really trying to cover the whole spectrum of the disease process. One of my main focuses is on the immune system. As sort of my intro mentioned, trained in immunology. So what I want to do with cancer therapy is to harness our immune system and try to direct it at treating cancer. About a decade ago, there were a number of immunotherapies that were FDA approved to treat a variety of different cancers. These have not worked as well in colon cancer as they have in other cancers, but some patients are still benefiting from those. So we're trying to find new and better ways of harnessing that immune system to go after cancer. One of which are our cancer vaccines. These work a lot like vaccines that we use for infectious diseases, so work very, very similarly. But instead of training towards an infection, we're training the immune system towards cancer. We have one clinical trial that's open right now, testing this new vaccine approach. It's in a phase 2 trial where we are enrolling patients. I don't lead that trial. I work with a medical oncology colleague of mine who actually sees patients and is the PI of that trial. And we have another therapy that we're trying to start up later this year in a phase 1 trial for more advanced disease. And we have a couple of trials open as well for prevention, where we are trying new oral compounds that could be given to try to halt the cancer process in its tracks and prevent cancer from forming in the very beginning. So we're trying to cover all that spectrum of the disease and find new options that we can bring to patients.
Excellent. Thank you so much. And what would you say to someone who is hesitant to participate in a research trial?
It's totally understandable. Hesitation, in general about new things, right? Every clinical trial is oftentimes testing something brand new, and even more so in certain communities, right? Folks that look like me took advantage of folks in the past, and instead of helping them, harm them in clinical trials. But today, every therapy that we have that is used to treat patients right now was tested in a clinical trial. That's the only way that we can find out how effective and safe brand new therapies are, is in clinical trials, and to ultimately bring them to more patients and start to impact lives is through those clinical trials. Everything that there are many steps in the process, in our laboratory, when we work with the FDA, when we work with institutional review boards, there are many steps in the process to minimize the risk as much as possible, so that anytime something brand new comes to patients in a phase 1 trial, we've done everything that we can to know that it's going to be as safe as possible, but we can never guarantee that to 100%. So there are risks in enrolling in those trials, but we've done everything that we can to minimize those risks.
And what inspired you to get into cancer research as a career?
So doing research is what I always wanted to do. I like, trying to solve the problems, right? There are challenges. So research is what I wanted to do, and have that around health. How can we solve health challenges? Cancer and the immune system, kind of putting those two things together, trying to harness the immune system to treat cancer, seemed like something that was potentially possible when I started, but wasn't really working yet. And I thought that that's something that I could do to, kind of make a difference and go after that.
And you mentioned studying currently some different vaccines for colorectal cancer. What would you say to someone who was a little bit hesitant about vaccines?
Vaccines in general. So vaccines are actually one of the oldest and safest and most effective kinds of therapy that we have in general. The first vaccines were actually being used hundreds of years ago. Folks don't quite realize this, but both in China and in Europe, vaccines were being developed to treat a variety of different infectious diseases. Louis Pasteur, very famous immunologist who did many things, was working on vaccines. And so in many ways, we've been studying these for a long time, hundreds of years. We've been studying the immune system and the interaction with vaccines. So we actually understand very, very well how they work, what kinds of risks that they have. And for the most part, we don't do anything that novel. Many vaccines that we have today are oftentimes just a killed version of the virus that causes the infectious disease. So we kill it. It can no longer cause disease, but we can still induce an immune response with that vaccine. And as we leverage, that kind of approach and pivot towards cancer, we do very, very similar things. So in our vaccine that we are working with now, we use a sort of inactivated version of the cold virus that expresses a colon cancer protein. And that's what we use in our vaccine. So it's actually a virus that we are all exposed to all the time. It doesn't cause disease in people. And we've kind of used that as a carrier to carry our cancer protein in there to activate the immune system. So while, in general, vaccines might seem like this very mysterious thing, we in the scientific and clinical community, we actually know a lot about them and understand them very, very, very well.
Excellent. And we do have a question from the audience here. So what strategies do you use to reach men and enroll them in clinical trials?
We have actually, I'm a little bit removed from that, but we've worked with a couple of folks here at Jefferson to ask in the very beginning the questions about what are the sources of hesitancy for patients. So asking, and that was one of the ones that came up, men were more hesitant than women. So asking those questions, finding out what the barriers are to joining trials, and then trying to provide information to them to overcome those barriers and get enrolled is one of the major things that we're doing. Not so much me, but other folks here at Jefferson that we work with to overcome those barriers.
Great, thank you. And if you could leave our audience today with one take home, one key message, what would that be?
Yeah, so it would be the same one. It's screening. Screening is so important. The return on it, sort of investment in doing that, it's actually, I've already had a colonoscopy. It's really not a big deal. Take a nap, take the afternoon off, and go through that. You have to have the opportunity to do that, right? That takes, there's some privilege involved in doing that. But it's not painful. It's relatively easy to do. And the return on that is enormous, right? It can be decades of life that you're given by catching that cancer very, very early. So it's something that I would encourage everybody to do.
Great, thank you.
Hopefully you can put me out of a job. If everybody were to get screened, then none of my immunotherapies would be needed.
I hate to say that that's a good goal, but it sounds like it is.
There's other problems I can work on.
Well, thank you so much for your expertise on research in colon cancer today. We appreciate you taking the time to be here with us today.
Happy to do it.
And that it was our final panelist for today. So we will bring it back to Dr. Lopez for some closing remarks.
Great, thank you. That was great, Rebecca. And thanks so much to all of our participants. Thank you, Dr. Snook. Thank you, Ms. Cox. And I'm not seeing everyone, but thank you, Mr. Rodriguez. So thanks so much, everyone, and thanks for everyone who was able to join us. Our work is very much in partnership. So yes, we're the Sidney Kimmel Cancer Center at Jefferson, but we work with our communities. And so want to give great appreciation to the Camden Coalition for their partnership. And it's really together that we can work to keep everyone healthy, and also our partnership with the Colorectal Cancer Alliance. So thanks so much. And, if you have questions, talk with your doctors, let us know if there's any way that we can help you. And we do have our study. If you're interested in getting screening, please, and I'm not sure if, I guess people can probably see it, okay, but please reach out to the email that's on the flyer. And we have clinical trials that are available. So if you're interested, talk with your doctor and learn more. So thanks everyone. And I think you've heard the message so strongly. Screening helps. Listen to your body, talk with your doctor, and get tested. So thanks everyone, and enjoy the rest of the day. Enjoy a really fruitful life, because you'll get screened and be well. Thank you. Thank you.